patients, the vessels tend to be very heavily calcified.
Yes.
And imaging either OCT or an IVUS both give us great insight into how to tackle the lesion. And here we chose to do the OCT because his EGFR is quite reasonable. The other option definitely would have been this IVUS. So now we're taking a scoring balloon.
Yes, Fazila, let me just, wait a minute. Let us discuss this because a lot of things to be learned from these cases. So, as I said, that superficial calcium can be handled with the rotor, but what about the deep calcium? So, as it is a 360 circumferential calcium, the stent may not expand fully. So, in that case, you may think about IVL or very high pressure balloon, opium balloon, something like to make the vessel fully open before putting a stent. So this is my proposition about this case, that before putting a stent, you make the bed very, very clean about the possibilities of stent under expansion can be mitigated before putting a stent. And other one is that I think single stent strategy will be my proposition in terms of left main proximal LAD. Circumflex, as you see, the angle is such that it may not close completely. Even if it closes, if the TB2-3 flow, it will be enough at this age because LAD is very big. This is my opinion about this case. Thank you very much.
Thank you.
Thank you, Professor Malik, for your brilliant case presentation up to this. And what Dr. N.M. Mobrajawan told, I do agree with this, that regarding the plaque complication further, whether you have any idea, you have any
Totally. I also totally
plan.
agree with you. And that's why we just now did further class modification with the scoring balloon went up to 24 atmosphere.
Yeah, and also dog boning
and as
effect
you
is
can
there.
see, the balloon has opened up quite reasonably well, right?
Dog boning effect is there, madam.
Not everywhere. Can you show this? This
Yes.
is not significant. This is, I would say, acceptable. This is not significant dog boning. And we went up to 24 atmospheric pressure, and that is so true that you really need to prepare your lesion very, very well before you embark on any kind of PCR procedure of putting a stent. And now we think that we are quite happy with using the rotor 1.25 and then 1.75, and then subsequently we went for. Okay, so now we think our lesion is pretty well prepared and we are planning to take our stent right now. So let's see, fingers crossed. We feel that the lesion is pretty well prepared and the onyx will deliver well.
Fazila, this is Ramesh Dagabadi.
I'm lovely to hear you. Thank you so much for coming to Bangladesh. We're so happy that you could make it, and we would love for you to come to our center as well. Visit us if you have time.
Sure, thank you. And I think you're doing everything step by step in left main, which Imad will be showing in the next room as well. So I think the discussion is, number one, Dr. Mazmin was mentioning about the rotor shock or rotor cut. So further debulking of the lesion or plaque modification after rotablation, obviously with the 1.75 curve, is being investigated. Whether rotor cut or rotor shock is going to be better, which we don't know yet. But here you went with the high pressure balloon with the cutting balloon, I think, and a scoring balloon. And we would like to, I mean, you're doing a stent actually, but I would have loved to see another OCT run or an IVUS run at this point of time. Are you planning to do, what are you planning to do with the circumflex? That's the other question that I have.
So this is actually provisional. Let's see how it behaves. If we have significant plaque shifting, maybe we will go for a stent strategy. Right now, we felt that the lesion was pretty well prepared, but we could do a run again. And as you can see, that the stent went very easily. There was no resistance whatsoever. So let me just position our stent and.
So Appa, there is another question that before you proceed, that whether we should be going for the circumflex as well or not. So
Do you want us to go with for the circumflex? I'm open to discussion. We have not yet deployed our stent, and if you want the upfront double stent strategy, we could always switch to a decay flush even now, and we can also remove our stent and have a look with the OCT. That is also an option.
So now I put the emotion aside. If I go for a two-stage strategy, I always like to check out the circumflex. Like you are either do an IVUS or do a physiology, do something. If you have any doubt, I just one case last week, the circumflex ostium looks angiographically good. Yeah.
We're just doing the LED now, so we are open to your suggestion, Hakim. As you can see, the left main is still there. We're just taking this step for the LED. Okay, so now we are open to doing the IVUS or an OCT, whichever you want, before we tackle the left main. Okay, so this is just. So this is just tackling the LED lesion, and as you know, by OCT we saw that the lesion was 51 millimeters in length. So we chose a healthy segment and we have deployed the stem. Now let us do pull back a bit and going up to higher pressure. And as you can appreciate, after the rota with 1.75 per and with scoring balloon, which we went up to 24 atmospheric pressure, the stent went very easily and it got deployed also very nicely. And as I was saying, when I was taking the wire with the microcatheter, even I was struggling with just the wire and the microcatheter. That was when we decided that first we would take a 1.25 bird and then take a 1.75 bird. Otherwise, we might have problems. So you can see that the rota has done a fantastic job of opening up the vessel, and that has been further helped by the scoring balloon that went up to 24 atmospheric pressures. Now let me do post-dilatation, and after this we can do another OCT. Now you want to go.
So what we are seeing here, step-by-step process.
You want the OCT or IVUS to the circumflex?
Yes.
In the OCT, let me just show you the OCT didn't look that bad. Okay, let me just show that to you, and let's do the post-dilatation in the interim period. So can you see the OCT, please? Is that the sir? Yes.
Imad, do you have any comment?
You can see the OCT, right?
Yes.
And the third OCT looks quite nice.
Yes.
So I just wanted a comment from Imad because he's watching the whole thing. And then Dr. Shah.
Well, I think she's doing fantastic, anyway. It looks to me simple bifurcation. What we have been seen by OCT, I think it is single stenting, and I will check after stenting and check circumflex. If there are any compromise on the ostium, I'll take some, some provisional to do something or not. So I think it is simple bifurcation, simple stenting, crossover stenting from LED as she has done. And we'll see what will happen to after stenting to circumflex.
Dr. Vinita, would you like to say something regarding this case, please?
Well, I agree with all the comments made so far, so I'm not going to repeat those. I think the only additional thing, particularly for our junior colleagues in the audience to remember, is that here they used a scoring balloon, so they went up to a high pressure. If you don't have a scoring balloon, you have a cutting balloon as an option. Just a reminder that you don't necessarily need to continue to inflate the cutting balloon until the waste is gone. The goal of the cutter is simply to cut into the calcium. And then you can follow that with the non-compliant balloon and take it to high atmosphere and look for that expansion. And the reason why I just make that comment is because if you do try to keep going up on the cutting balloon, several inflations in one area, looking for that dog bone to disappear, that you do risk perforation. I've seen operators do that, so just to make that additional comment.
So we are getting a 4 by 18 millimeter, another stent for the left wing to LED, and let's see how it behaves, and after that we will again do our imaging. Okay, Dino. Okay. So we're taking our stent now. Onyx. Another onyx.
Madam, can you please explain?
We take the onyx.
Madam, can you please explain
Yes, please.
the choice of stent in this situation? Why you are using onyx in this particular anatomical situation?
Okay, so onyx, one of the stents that is very deliverable, number one, and so for a calcified patient, obviously that helps. And also, it can be expanded according to your choice. And so tree can be expanded up to even a 4 millimeters. There's a chart and I post it to you. So when there's a discrepancy in the size between the proximal vessel and the distal vessels, obviously this would be your first choice because so at the proximal landing zone, we saw that the diameter of the vessel was 4.3, right? 4.3, 4.4. And distally, it was like 3.2 the LED. So there is a discrepancy in size, so this would go very well. So we're taking our second stent, goes very easily. Again, we position our stent.
And any advantage of the cell diameter or cell design?
Absolutely. So the side branch accessibility is a lot easier, which helps. So we're pushing, I think we are, let's have a look. So we want to keep enough 6 to 8 millimeters at least for proximal optimization. The osteo of the left wing we've already seen by imaging is fine. So let me see. You think this position looks all right? Yes, so we're deploying ourselves. So there is a nominal pressure, will go down. And as you can have a look at the hemodynamics, the patient is hemodynamically doing quite all right. So we are doing another inspection. And now we would do, after deployment stent, we do proximal optimization with the 4.5 by 8 NC balloon. And here we are using the NC Euphora. We'll give a bit of nitro. The circumflex looks quite good. Can we have that picture run again? Yes. But there's disease, I think, there. Yeah, it's diffuse. The circumflex, I believe, is diffusely diseased, right? And he's had a very long history of his coronary artery disease. Like in 1998, he had 3 bare metal stents implanted, and then he had a surgery done. So now we're taking our balloon for proximal optimization.
Madam, would you like to evaluate the osteum of the circumflex by some techniques like FFR or something?
Absolutely. So what we did is we first did the OCT, and then we found that the circumflex was quite clear disease, and we can take an imaging modality definitely.
And after port, we shall also be able to evaluate the sacrans. It may remain well.
So with proximal optimization, obviously for beginners, you use a short And one size larger balloon, it has to, ideally it has to be a MC balloon, position it at the carina and go up to high pressures, which we are doing. So now, we will rewire the circumflex. And we need to do post-dilatation of the LAD stent. We have not as yet done that. LAD post-dilatation, yes. First we will rewire the LCX, we need to do post-dilatation. This is the LCX wire. So we are taking another wire, and we usually rewire with the help of a microcatheter that